We've got 4 speakers and 3 presentations this morning, all of which will be available on the website and the app. So we have Jane Bake from St Barnabas, Lincolnshire Hospice, Director of Service Innovation and Integration, and then from Ashgate Hospicecare, Lucy Nickson, CEO, and David Brooks, Consultant in Palliative Medicine, and then following up with Fiona Murphy, talking about integration across Bolton and Wigan NHS Foundation Trusts. So firstly, can I introduce Jane?
Good morning, and thank you for inviting me to talk to you today and share some reflections on our Hospice in the Hospital project. I'd also like to take an opportunity to share our experience of working with and in acute hospital trusts. I should say that this is very much about our experience as an organisation. I'm sure that some of what I say will resonate with the experiences that you have had, but others may be very different. I'd like to take a few minutes to talk about the developing relationships, the early work, what went wrong, what went right, and what we learnt. I'll then talk more specifically about the hospice in the hospital and another project that has led on from that. And finally, a few reflections. Firstly, perhaps a little bit of context about Lincolnshire. It is geographically the 4th largest county in England, but with a sparse population of 750,000 and a death rate of 7,500 a year. It has a poor transport infrastructure. It's served by an acute hospital trust with 3 hospital sites, each an hour's drive from the other. Like many hospital trusts, it is financially challenged and was one of the 11 acute hospital trusts to be selected for the KEO review and put into special measures. The Voices survey also told us that Lincolnshire wasn't doing very well at end-of-life care. And I think it's against this backdrop that our then Chief Executive, Sarah Jane Mills, with our mission statement ringing in her ears, that we would enable the people of Lincolnshire to have access to high-quality palliative and end-of-life care, approached Jane Lewington, the Chief Executive of United Lincolnshire Hospitals. Can we talk? This was the start of a relationship, 2 leaders who were able to find common ground and shared values, whose individual and joint aims were to improve care at end of life for patients in Lincolnshire. It began by exploring the possibilities, challenging each other's perspectives, really getting to understand the reality for each organisation, and deepening respectful relationships so that problems could be articulated, shared. It took time and it took persistence. When meetings were cancelled, it was about remaining positive, keeping each day as a new beginning and not looking back. It was the opportunity to identify the opportunities. And at this stage, the picture was really hazy. And many of you will recognise Claude Monet's work there. It was high level. It was focused on values and feelings. It was full of potential and possibilities and opportunities to shape something special. It was at this point that this picture was shared with the executive teams in both organisations. And at a high level, we all agreed we needed to work together to get it better for patients. But how could we do this? Well, sadly, we went into management mode and we got down to the detail. And for those of you who might not know, that is the work of Archibald Thorburn. Yes, we all started to feel very comfortable with the familiar, the Memorandum of Understanding, a palliative care board, a strategy, and a Directorate of Palliative Care, working with our shared consultants. We were all in our element with the familiar. But actually, the impact was minimal. In fact, as St Barnabas, we were viewed by others with suspicion and even hostility. We hadn't really communicated what we were trying to do, and we knew that we needed to do it differently. And then as these things happen, an opportunity presented itself, or rather the opportunity to solve a problem arose because of the agreed picture and the relationships. And this is where Hospice in the Hospital was born. South West Lincolnshire CCG had identified a local palliative care need for beds. They had been out to procurement without success. And although this had been a long-term aspiration, there just didn't seem to be a solution. The procurement process certainly hadn't stimulated the market. But again, it was about looking at the problem, building the relationships, and with a will at the highest levels to take some risks and to work differently, we were able to turn the possibility into a reality. 3 organisations working together, 3 very different cultures, and we had to aim to address this complex issue. But we had a clear brief about bringing together the skills of the people involved in each organisation to deliver a community-facing 6-bedded nurse-led unit, medically supported by GPs and with support and leadership from hospice staff. And now the action involves staff at all levels, from all of the organisations, the CCG, the acute hospital and St Barnabas. It involves facilities and infection control, finance and HR, catering, pharmacy, the trust solicitors, and of course, the clinical staff. So it was about bringing together all of those skills. And so what if our visions initially were all just slightly different? We were together, we were sharing, we were shaping. The key role of the hospice was to ensure that the patient was kept at the centre of our focus and of our discussions. And no, that isn't rocket science. It's what we do and aim to do every single day in our practice. But it was unbelievably powerful. It helped people to divest themselves of the trappings of their own organisations. And once they'd done that, it changed their thinking. But, you know, we had to do it every time we met. with every person we met. And that's about the culture of an organisation. That's about the barriers and hurdles that are put in the way of people trying to do what is right for patients, because that's what everybody wanted to do, but sometimes they got lost in the morass of process. It also helped us to get past some of the significant anxieties that the project provoked, especially from a governance perspective. When we reflect as a team on those times, it's the human reactions that always come to mind. "You want to do what?" said the chief pharmacist when we described how we thought we might be able to manage medicines in the unit. And this happened time and time again. But each time, with the patient at the centre, we were able to reduce their anxieties, develop a plan to overcome the obstacles, take calculated risks and manage them in a way that satisfied a risk-averse culture, but achieved the outcomes. And this is what happened throughout the team. Whilst we each had specific work areas, there were key things that we all had to do every time. And it was actually our Director of Finance that really articulated this most clearly. It was about sharing and selling the vision and the values, understanding the experience of others, providing that impetus and energy, and helping people to do things differently. And there were some enormous rewards, and I'd just like to share one of those examples with you because it's had a profound impact on the way that the unit now works. Using lean processes, we were mapping the pathway for a patient in the unit to have a blood transfusion. And what became very clear is it was very complex, and it was not going to be a good experience if we continued to do what had always been done for the patient. I guess it's what Jake Garber was talking about the other day about designing the prototype, and I've just clicked into why the lean team who were supporting us kept saying, if you can't draw it, it won't work. It was one of the acute trust matrons who suggested we created a virtual hospice bed to provide the medical cover we needed during a blood transfusion. So we moved the expertise, not the patient. Brilliant. And even more so because this principle now enables us to respond to dying patients in A&E, ensuring that the patient can be cared for on the unit with medical support in the most appropriate place. So the unit opened on the 8th of September last year. It's now been open for 14 months. During that time, we've received 189 patients, the majority of whom have received end-of-life care. The majority have also been admitted from the hospital, so we know from that perspective that we have avoided a significant number of hospital deaths. The unit has provided choice for patients. It's provided admission avoidance for patients, rehabilitation, and symptom management as well. Most patients have remained under the care of their own GP, retaining that continuity and relationship. And that's not just been for GPs in the very local vicinity, but GPs from much further afield within the CCG. But we need to improve. We need to improve the number of patients coming directly from the community if we are to ensure that the unit remains financially sustainable in the long term. This is cultural change in habit. It won't happen overnight. It's going to take time. But it's a wonderful environment for patients. One of the first comments that we had from a patient was, "This is just a wonderful place and it will become very popular when people get to know about it." So we've managed to improve patient experience and family experience, but it's also given us a platform and enabled us to have an impact in other ways. As part of the work we did on governance, we incorporated within the Acute Hospital Trust policies addendums for the unit, specific end-of-life care within these policies. At the moment, it is only for the unit, but it's there for everybody to read. And one of our next steps in working with the hospital is to actually enable those addenda to be used for end-of-life patients throughout the hospital. It's small steps, but in a risk-averse organisation, that's what you have to do. Our learning extends to our relationships with GPs too, and to the CCG. When something on the unit didn't work, our relationships were strong enough that we all came together to resolve the problem. It wasn't about blame, it wasn't about accusations, it was just about, we can get this right, we can do this. I think one of the things that has surprised us most is the complexity of the patients that have come into the unit. It's been far greater than we imagined, not from a physical perspective, but from a psychological, social, and spiritual perspective. And we were very fortunate that as the unit opened, we also appointed, between the two organisations, a joint chaplain for palliative and end-of-life care. And her work within the unit has actually been absolutely pivotal. So we had the 26-year-old patient who came in a few weeks after the unit had been open, who screamed every time she was left alone. That's very hard on a group of staff who are still getting used to working together as a team and working in a very different environment. And our chaplain was incredibly important in supporting both the patient, the family, and our staff on that unit. The lady who, with a diagnosis of MND, whose decline was so rapid that she died within less than 6 months of her diagnosis, the continual and progressive loss of function created huge existential distress. The busyness, as staff found out, was very different from that on the acute wards, where the physical domain of care is often the only focus. In the unit, it's all domains, and it changes the nature of the work and the skills required. And that's something we're still working on to help the wider hospital site understand. We always anticipated that the unit would provide outreach to the rest of the hospital wards, and it was working to some extent, but we've refocused the role of the ward leader so that we now have specialist palliative care support 5 days a week to the other wards in the hospital, creating better links and also support for our consultant who works part-time. We have a beautiful building, and we were very privileged last week to receive the Builder Better Healthcare Awards. But we see this as just the end of the beginning and the start of the next part of the journey. There's still much to do. We need to increase the number of patients coming from a community to ensure we're financially sustainable. We need to influence the wider community pathways as neighbourhood teams, complex care navigators and electronic patient registers come into play. It's also about extending the scope of the unit to support symptom management by other specialist nurses. For example, our heart failure nurses being able to bring a patient in to support them where they couldn't do at home, but where an acute hospital mission really isn't required and isn't the patient's choice. There's a level of trust now, and this has resulted in us being asked to deliver end-of-life education across the 3 hospital sites. Whereas the hospice in the hospital was very much a bespoke solution for one locality, it is the catalyst for other work, and education designed to embed identification of end-of-life care needs and to grow confidence in communication skills with patients and families is our next step. We are working with the hospital. It's a sequin payment, so that's a bit scary because it's a lot of money, and it's a bit scary to deliver it on behalf of another organisation and to be doing it differently. We've piloted it, and we've seen that working in a different way has increased confidence, has increased understanding. The hospital have a system called Plan for Every Patient, which they use to monitor flow of patients and the tasks, the actions that are required for each of those patients. There's a board meeting every morning, and the education facilitator works intensively at those board meetings with those teams to help them to identify their patients. It's really about embedding that work, that education in their work. So these are all the building blocks that the development has enabled us to put into place and that we will now begin to gradually link together. So some final reflections. Yes, the hospice in the hospital has had a fantastic impact on patients and families. They've told us that in numerous ways. They have a choice of environment. But it was always intended to be a catalyst for wider change, and now, after a year, is the time that we really have to start doing that work. But it's also provided a level of learning that I don't think as a team we would ever have thought possible, and that we're going to take forward into all of the new projects that we take on. It's important that we have transformational leaders, but it's also important that the translators and doers have the skills too. In large organisations, we're going to spend time making those connections and links because otherwise they don't always happen. We always need to ask, what does this mean to you in your world? And as one human being to another, how do I best support you to manage anxiety and risk? How can I help you to see the possibilities, to be brave and to work differently? That's scary, and there are lots of ups and downs. And a final thought. It's about the small steps towards that slightly hazy vision and a journey that continues to embrace the possibilities and opportunities along the way. Thank you.
Thank you, Jane. It's very refreshing to hear somebody being honest about the challenges. We all talk about partnership working, but we're not always honest about the sheer effort and honesty it takes to make that work in practice. Please make a note of your questions, because obviously we'll take those at the end. So next we have David Brooks, Macmillan Consultant in Palliative Medicine at Chesterfield Royal Hospital and Ashgate Hospicecare. He's obviously also the immediate past president of the Association for Palliative Medicine, and Lucy Nickson, who is also the lead for end-of-life service improvement in North Derbyshire, as well as being CEO for Ashgate. Slightly scarily, when they arrived this morning, they said it wasn't quite as billed, but they assured me it's linked with the theme. So we'll wait to hear. Thank you.
Good morning. Yeah, if you thought we were going to talk about the acute frailty unit, we're not. So what we're actually going to talk about is our hospice CNS service, but more widely, the integration and the partnership that we have with our local acute trust, which is Chesterfield Royal Hospital. So just for a bit of context, Ashgate Hospicecare in North Derbyshire, serving a population of around 400,000, urban and rural communities. Chesterfield Royal Hospital is our biggest acute FT, but our patients actually go into quite a number of acute hospitals around us. They'll go towards South Yorkshire, into Sheffield, to Stockport and into Mansfield, Kingsmill. But the hospital that we have the strongest relationship with is Chesterfield, and that's serving a town of around 100,000 people and total rural catchment area 400,000. There are visiting site-specific oncologists on most days, some chemotherapy on site and radiotherapy about 14 miles away in Sheffield at the Cancer Centre at Weston Park. There is a big development happening in Chesterfield at the Royal Hospital. There's a new cancer centre, which is a real opportunity for the people of North Derbyshire, and there will be a palliative care presence within that cancer centre as well. And the hospice is about 3 miles away, and we've got a 21-bedded inpatient unit, day hospice, CNS services, therapy services, and with a long history of a relationship with other organisations in the area. So when we're talking about specialist palliative care services in the acute hospital, we're talking about our medical consultants and also our CNS service. There were just 2 palliative care consultants until last year, and the hospice and the hospital wrote a joint bid together for funding for a 3rd consultant, recognising that there was a real need, and we were successful with that, and the CCG has provided that funding, and we've had a 3rd consultant in post since January this year. And what that's meant is that there's been a much greater opportunity for the consultants to work towards a service which is about the whole population across all settings, so not just either in the hospice or in the hospital, but actually much more of a focus around the community side of palliative medicine, and also to cross-cover when they're away from work and committed to other things, and to really step up the education that's provided, particularly to other clinicians in North Derbyshire. So that's really positive. The CNS service that the hospice employs, there are 13 of them, but there's a small team that we're going to talk a little bit more about that are based at the hospital. It's actually just 3.8 whole-time equivalent, and that's made up of some Band 7 posts, but also just 1.6 of that is Band 6 development posts. And the reason I say that is because those of you that have got CNS services will probably also be experiencing some difficulties in terms of succession planning, because we've got some fantastically experienced nurses, but actually they're heading towards retirement age. And so we've been talking for a couple of years about how we manage that. And one of the things we're doing is growing our own, if you like. So we've got a number of Band 6 posts who are working towards becoming those independent CNS nurses. And we will be looking at also the kind of fluidity of those roles across all settings and how we can make them really attractive and retain them in the future. So the hospital team, they're a nurse-led service, but as David will talk about, it's part of a multidisciplinary service. And the thing is, it's not new. They've been doing this for 22 years. So yesterday in one of the sessions, I was listening to somebody talking about partnerships and how sometimes we inherit partnerships, and this is very much one that I've inherited. I've only been at the hospice for nearly 3 years.
So Lucy asked me to talk a bit about the history because I've been there quite a bit longer. And in fact, the hospice started in 1988, and with significant input from one of the hospital consultants, an anaesthetist who specialised in pain medicine, who was a leading driver in getting a hospice for Chesterfield. And a few years later, in 1993, the government put out a grant for nurses, palliative care nurses in hospitals, and the board of the hospice and the hospitals were persuaded at the time to channel that money through the hospice so that the nurse could be part of the CNS team that was starting in the hospice and be part of a team rather than on her own, although they did work in the hospital alongside the anaesthetic pain management team as well, so they had a bit of ownership over there. This is from the first service leaflet. The hospice management is aware that hospice care is not possible for or desired by everybody. This initiative is aimed at bringing a part of the hospice into the acute environment. Quite visionary at the time. A year later, in 1994, they'd realised that they'd opened the floodgates and the work was too much for one person, and the hospice then put in its own money to employ a second nurse. So that was 1994. Moving on to 1998 is when a Macmillan grant was bid for, which resulted in me turning up as a Macmillan consultant, working in the hospital. But quite soon after, a few months after, in fact, the hospice medical director left. He retired, and there was a gap. So we couldn't leave a gap, and so I ended up working across hospice and hospital until we got a replacement consultant. A few years later, there was a gap, not for funding reasons, but for other reasons. And so the money from the hospice that had previously been providing medical director role, which had moved on from the anaesthetic pain management person, that moved into providing our second consultant, and we both worked across both settings. A palliative care strategy group was formed around that time with representation from all over and led by our health authority. And it was very clear that one central tenet of the strategy was that we wanted integrated palliative care services. We didn't want little bits and pieces working separately. So across the whole of North Derbyshire, the principal premise was that palliative care services should work together. So when the Department of Health, for those of you who remember, I think it was Hazel Blears in 2005, put 50 million for palliative care that we all had to invest. We had a strategy group which looked at how we could provide that across the board, and part of that was 2 additional nurses in the hospital because things were expanding. It also provided some secretarial, 6 hours of additional secretarial hours for the hospital team. Now, interestingly, a few years later, that money was then rolled into baselines, but a few years later, the hospital appointed its finance director to chief executive, and I hope this is Chatham House rules here. My dad, who was a finance director of a big organisation, said, "Oh, that's an unwise move. Your finance director knows the cost of everything and the value of nothing." And so very soon there was a workforce review, and most of the site-specific CNS services were decimated. And in fact, the secretarial services were also decimated. Half the secretaries left in this workforce review. Interestingly, the palliative care CNS services, because they were managed by the hospice, were protected from that, but we lost our secretary. And in fact, currently, still, my secretary works for endocrinology, diabetes, nephrology, neurology, cardiothoracic surgery, and palliative care. Think of hearing that on your hands phone. So, move on a few years. Lucy's already talked about retirements and imminent retirements and needing to get development posts. But in 2013, Lucy turned up and, new chief exec. A lot of the organisation had changed. A lot of the organisational memory had gone. The CCGs had replaced health authorities and PCTs and all that. And so there was no sort of memory that some of this had been NHS funded, and it had all been lost anyway in baselines. So one of Lucy's early comments to me was, why are we paying for this service in the hospital? And that's where this conversation starts, really. Why should a hospice pay for a service in the hospital? About 30% of patients in a hospital at any one time will be in their last year of life. 10% of patients on hospital wards will die during that admission. And the aim of the hospital supportive and palliative care team is to provide that specialist palliative care assessment, advice and support for adults who have a life-limiting illness and also their carers when they're admitted to hospital, when they come into the emergency assessment unit or the clinical decision unit, or when they're attending outpatients or visit ED. We are the palliative care representation in there. And also, like all hospice services, we're not just supporting the patient and the carer, but also supporting the teams, the generic teams who are supporting those patients and educating them alongside that. So we're giving support to both health and social care professionals. We get referrals. Some of them are on our referral form, but a lot of the time we also get phone calls. We get people calling for advice, which turns into a referral. We get people tapping us on the shoulder as we walk around the hospital saying, I think I've got somebody for you. While you're here, doc, while you're here. But we also proactively look for referrals. So, for instance, we'll go onto the emergency assessment unit every morning to find out who's been admitted. What are these people? Are there any that should be having palliative care? We also have an alert system which tells us when anybody who is seen by palliative care services in the whole of North Derbyshire comes into hospital. The nurses will get a text on their phone. I run an unknown primary service, which is really there because this group of patients, unknown patients who present with malignancy of unknown primary, are often extremely poorly, but for some reason the teams felt that they needed to make a diagnosis before involving palliative care. So as I'm the diagnostic service, I can go in there and say, actually, it really doesn't matter where this liver metastasis has come from in this person who's bedbound. What's important to them is what happens now, their support and their care. So we get palliative care in very early. We both record our assessments in the hospital notes, but also on System 1, which is our palliative care recording system, which is shared across the whole palliative care team in North Derbyshire. So that when we see somebody in the hospital, we can actually see what's been going on if they've been seen by the palliative care team at home. But likewise, when they go home, the palliative care teams who go into them have sight of that when they go and see them. Our referrals have been going up and up and up, and are still going up. And there are a few years when they dip down a little bit, but generally the whole trend has been upwards. What are the strengths of being together with the hospice and the integrated palliative care team? It's principally about joined up working, one side knowing what the other side is doing. So I was in the community MDT yesterday morning, and we talked about somebody who had gone into the hospital, who the team were just picking up. But I was able to take some broader intelligence, that sort of intelligence you don't necessarily get in notes, about that patient back to the team that were seeing them. The one clinical record is superb, because we can really see what's been happening in the other places. And as I say, being managed by people for whom palliative care is a priority really helps us to have a management who understands what we're all about. It's not about counting the numbers and the beans, it's about the quality, and it's quite different to some of the other services. What weaknesses? Well, being part owned by the hospice, you can mean that there's a lack of ownership by the hospital management team and a confusion about managerial responsibilities. On the converse, can be seen by some people, you know, hospice board, is this really our responsibility to be providing nurses for the hospital? So when we do have initiatives like spreading out 7-day working, we can sometimes fall between the gaps there of whose responsibility is it to drive this forward. Lucy.
Just a couple of other things on the service itself and benefits. One of the things that the nurses talked to me about recently was the improvement of the flow from patients between the acute hospital and the hospice. And I don't think that can be underestimated, really, but also that ability to turn people around and to prevent an admission, so to anticipate their needs in the emergency medical unit and get them home before they actually become an admission. So there's a lot of intervention which takes place within that multidisciplinary team that's really important and is about the link to the hospice and the community as well. I just wanted to pick up on that. A couple of other considerations. Service level agreement. I'm not a control freak, but you know, there isn't really one, and that does bother me. And again, that's a sort of inherited picture. There doesn't really appear to have been any service level agreement for this particular aspect of service. There is one in relation to our medical consultants who are employed by the hospital, and there is one for the services that we purchase from the hospital, such as pharmacy or some aspects around IT, etc. So we wrote one last year, and it covered off things like management and governance arrangements, funding, hours of work and things, but it still hasn't been signed yet by the FT. And I don't think that's a problem because this service is so well embedded, but I think it adds to what I'm going to talk about in a minute in terms of challenges and some of the frustrations, because it does matter actually that we all agree what we're working to, and I think it will matter even more. And I think the reason that is because there is sight of this service in the hospital now in a way that there perhaps hasn't been before, but I'll come on to that again in a minute. I want to touch on branding, because part of my concern, I suppose, is that I don't think the hospice nurses have been as visible in the hospital as we would like them to be. Improvements have been made, and we've looked at their badges and we've talked about uniforms, and what the nurses do is they talk very clearly with their patients and other staff about the hospice and about the relationship, and that's hugely important. But you know, that's something which I think should be thought about when you're entering into these relationships. In terms of cost, it costs the hospice £181,600 at the moment every year. And I am still asking the question, should we be doing this? I really still, you know, David and I still, we don't fall out over it, but we have some challenging conversations about it. And I think what's really interesting is that our own strategy as it's emerged from the hospice, I think will be revisited in terms of what we're paying for and what the outcomes are with our own board, and these conversations will continue to rumble. I just want to pick up on the context, because I think whilst this service has been around for a long time, what's different in North Derbyshire is the backdrop. And what many of you will probably know about your own areas is that there are big programmes of work around improving integration in terms of health and social care. And a lot of that is about increasing service provision in the community and getting people out of acute hospitals when they don't need to be there, etc. In North Derbyshire, we have a programme of work called the 21st Century Integrated Care Programme. And there are 9 work streams, and one of them is end-of-life care. And David and I are both clinical and project lead for that. And it's a great position to be in, because the hospice is on the radar of people that are talking about service planning, and we're able to lead and influence in a way that we perhaps haven't been able to before. So that's really important. The reality is the integration and the partnership working at patient level and at clinician level is there, and it has always been there. But perhaps what hasn't been there is the kind of impetus from the other bigger players around us to recognise the contribution of hospice care and palliative care. And I think that has given us a real advantage, and it feels like there's a real opportunity to start to make quite a difference and to work with commissioners and the bigger providers in a very different way, certainly in a prime position to start to influence and talk about 7-day services in relation to palliative care. So I think that's an important backdrop. There are challenges. Whenever I come to conference and I hear people present about fantastic initiatives, I'm always really inspired and go away thinking, well, what can we do? What are we already doing? But I also come away thinking it can't be that easy. And the reality is, with this situation, it isn't easy. And I think there are lots of politics with a small p, and that is something I think that when you work in a smaller organisation like a hospice, the decision to action time is tiny. And that's been incredibly liberating for me coming out of the NHS and working in the hospice sector. But then trying to work with a big acute FT to get changes through that are relatively small is just sometimes impossible, because you get sucked into the politics of working in that environment. So I think that, that is a word of caution, and it's something that that can be quite challenging. Communication is an issue, and I know from talking to our nurses that internally communication can be difficult for them. So even though they've got an nhs.net email account and they're very visible, they've got fantastic relationships with all of the clinicians and departments, they get missed out of vital communication sometimes, particularly around planning. So you have to work quite hard at that. But I also think communication at every level, so, right through from the board and the chief exec is really important. And I've spent quite a bit of time in the last few years building relationships with the chief exec of the acute hospital. He's been over to the hospice. We've also pinched somebody who's become a trustee, who's a member of the leadership board of the acute hospital. And just a couple of weeks ago, I met a couple of non-execs and was chatting to them about the hospice's role. And they're really interested in the relationship and want to understand more about it and be able to influence positively at the board within the acute trust as well. So I think relationship building, talking really clearly about what the challenges are and getting people on side is really, really important. Funding remains a challenge, and even more so now we're talking about 7-day services. And recently the hospital had their CQC inspection, and they had a requires improvement rating, and specifically there were some actions around end-of-life care and palliative care, and that was about ensuring that they can deliver a 7-day palliative nursing service. And we had an initial meeting, and the paper was coming in my direction, and I was pushing the paper back in that direction. And, the reality is, I do not believe it is our responsibility to pick up the funding that will then close that gap around 7-day services. I also accept you have to be careful what you wish for, and we're in it, we're doing it, we're talking about integration, we're benefiting from the partnership working. We are putting money there, but I think that what we're expecting is that there needs to be some more funding from the trust in the future to expand that service. The hospices strategy, prioritising need ourselves. Our strategy is about increasing the footprint in the community, so we haven't allocated funding anywhere to the acute trust, and I think we have to keep that in mind. But I'm also trying to keep that bigger picture in mind, which is that we're talking about a population, and we're talking about the health needs of people that move in and out of systems and health settings. So we don't want to work as just a hospice and see the hospital over there and the community trust over there. We want to be part of that system. So again, it's this kind of conflict all the time and reminding myself, what's that bigger picture? Where are we going to? Relationships I've touched on. Meeting demand, I think it's a bottomless pit, personally, in an FT, and I think the nurses have worked really hard on their referral criteria and managing their caseloads. But as David showed, demand for the service is going up, and how we meet that demand in the future will require us to work more innovatively, I think. And then just in terms of conflict of interest, I noted at the beginning that there's a large build and development at the acute hospital, the cancer unit, which is fantastic. And we've talked to the hospital about how palliative care services can sit within that. But, you know, there are some conflicts there because part of the achievement of that development is about them having their own fundraising campaign and working with another large charity to achieve that. So it's about them balancing, you know, where does the hospice fit? And they've been very generous with us and let us have a profile in their foyer and reception area where we can promote our own fundraising. But there are clearly some tensions around that in the community. And again, those are the sorts of things that you need to think about and need to be managed. David's just going to pick up on the acute oncology service, aren't you?
Very quickly. The acute oncology services within the hospital are employed by the hospital. And so look, the opportunities there to sort of, there's a big overlap. And yet the opportunities to join up working are a little bit more difficult when you've got two groups employed by different people. I'm going to move very quickly on because I can see our time is just about up. There are other opportunities. We've talked about developing a skill mix within the CNS teams. We're also looking at developing advanced practitioner and prescribing skills in the CNS service as a whole. There's opportunities which we are just starting with our development roles to rotate in and out of teams so that the nurses, CNS in the hospital also have experience of working as CNS in community, and more rotation in and out of those settings will, I think, improve integration. We've already got a nurse-led clinic with the new build for the oncology service. There's perhaps an opportunity to have a drop-in clinic so that patients attending the oncology unit could actually drop in when they have a need and be seen by palliative care alongside their oncology appointments. And Lucy's already alluded to the developments on the 7-day service. The other development more broadly is that we would like to develop is actually within the out-of-hours service, the primary care out-of-hours service, having a CNS presence within that. And I think that's got us to an end. Yeah. Thank you.